at the beginning, this is a conversation I normally have in a little room with one or two people rather than a big room. What do we want to call it? Do we want to call it MTC? Do we want to call it medullary thyroid cancer? Do we want to not call it medullary thyroid cancer? What do we want to call it? Don't mind. Again, just in my style, we in my clinics, we have 10 minutes when we're really beginning to know people where we're exploring this, and after a while we actually start practicing the word so that it doesn't feel so bad and it doesn't sound so bad, because it's just a word, but it's a really important word, and I'd much rather we practiced and understood what we meant by it than some of the people I look after hear it for the first time 10 years later and well, you know, they never told me that. They called it C-cell hyperplasia, they called it medullary thyroid tumor, they called it functional thyroid, we call it all sorts of things. But it's that we mean the same thing bit. So in terms of emerging treatments for MTC, medullary thyroid cancer, I think we need to group them into two areas. One of them are strictly medical drug treatments, and that's going to be talking about something called tyrosine kinase inhibitors. And we'll go back and show a couple of slides as to why we call it that in a minute. Then there's the surgery, because we always think of new treatments as medical, but actually surgery is changing. And then I guess we can talk about what happens if the MTC is spread outside of the thyroid gland. What do we do about it then? And what can we do? And what should we do? And what are the options? Would that be reasonable? I haven't got any slides for this, so you're going to discover I'm a crap drawer. Okay. We're going to remember the light switch thing. Yeah. We're going to turn us all into industrial chemists. There's this problem. Right. There's this thing that normally switches this on, and then something happens. There's some steps in the way. Well, if we had to design a drug or design some drugs that might stop the problem, what would we design them to do? There's an on component, you know, remember this is a switch. There's a bit that senses, and then there's a bit that switches on. And then something happens down the road. What would we design?
The off switch it off, but also something to the sensor, make sure the sensors work.
Yeah, to try to correct it. Yeah, that would be the perfect designer drug, wouldn't it? What about if we go for some easier things as well, though? You know, that would be perfect. That's the holy grail. But what about something that's halfway? Well, this rep protein is related to a whole load of other proteins that looks similar, cousins of it. And they've all got one thing in common. And the thing they've got in common is this bit in the inside, this switch bit, the on bit. Yeah? That's called a tyrosine kinase. Fancy name. But that tyrosine kinase is switched on when that bit is activated, normally. And in MEN2, that bit's switched on even when that bit's not activated. Yeah? So the perfect drug would be something that switches this off by changing its ability to sense. But we probably go for, well, if we can't do that, what we really want it to do is screw this up. Yeah? And that's what the drug industry did. The drug industry designed something called a tyrosine kinase inhibitor. Says what it does on the tin. It inhibits tyrosine kinases. And some of them are little molecules, some of them are big ones. Some of them require you to have an intravenous drip, some of them you can take as tablet. We abbreviate them for obvious reasons. Tyrosine kinase inhibitor, bit of a mouthful. So we call them TKIs. Sorafenib would be a category. Two problems immediately with tyrosine kinase inhibitors. They cost a lot of money. Adverse effects. The money we can't do a whole lot about, so we're going to ignore that. They're not as cheap as chips. They're not the most expensive thing in the world either. Adverse effects. I explained that the RET molecule, it's got lots of cousins that aren't RET but look like RET. They do lots of other things. And they've got one thing in common. They have this bit on the inside. Now these cousins are really important for doing lots of things in the body. And while the drug industry and we and you would really like something called a magic bullet that just does the one thing we want it to, doesn't do anything else, we don't have a TKI that just inhibits RET. Not only does it inhibit RET, but it inhibits and blocks the other cousins of RET. Now, we don't want RET to work in MEN2, but we need the cousins of RET to carry on working. And that's the problem with TKIs. They don't just hit RET, they hit the other things as well. And those hitting the other things are responsible for the adverse effects. They have adverse effects. The commonest ones we worry about are something called hand-foot syndrome, where you get blistering on your hands and feet. Now that doesn't sound too bad, does it? Actually, it's really bad. It can be really nasty. And it's the commonest reason for us stopping them. You also get side effects of diarrhea. Now, one of the problems you get when you have medullary thyroid cancer making lots of calcitonin is diarrhea. You're not going to stick your hand up in the air and say, can I have a tablet that gives me diarrhea, please? Actually, I think I'm taking it to stop that, yeah? And the one we worry about a lot, though, are the cardiac side effects of tyrosine kinase inhibitors, TKIs, because they can cause heart rhythm problems. And as we're all really living longer, most of us are going to have heart problems. So we have a lot of worried people prescribing these. So there are trials at the moment looking at the use of how effective TKIs are in preventing the development. I'll choose my words carefully. It's not preventing the development of MTC. It's slowing down the progression or stopping MTC. So again, this is the bit about doctors say different things in different ways. So the diagram we use in Newcastle is this one. This is a hill, and there's a snowball at the top. And if your medullary thyroid cancer is spreading, it's rolling down the hill. But as it rolls down the hill, it doesn't stay the same size. The snowball gathers snow. What we're interested in, as a patient and as a doctor and a nurse, is how fast is the snowball going down the hill and how big is it getting? Because the two things tend to happen in parallel. What we really want is to push the snowball back up the hill. Get back in your cage. Yep. That's cure. Be quite nice if we could push it back up a bit. Yeah. And stop it. So the snowball's held. We'd call that remission. Stable. The other thing my mum used to say about doctors and medicine, you can tell she wasn't a doctor, she was from Yorkshire. She used to say, never go to a supermarket when you're hungry, because you'll buy anything. Yeah. So when we're really hungry, we'd probably go for, well actually, it'd be great if it did this. I'd go for that. But just getting it to slow down, I'd probably go there. And so the end point of the trials, what we're really interested in is how many people are cured, how many people are going to remission, how many people would just slow it down. We haven't had anybody who's cured. How would we measure this? How do we tell whether someone's gone into remission? How do we tell whether the snowball slowed down? We talk about something, you might think, well, how many have reached the bottom? How many people have died from it? Well, it's a long journey, this. Right? So we're not interested in waiting that long, thank you very much. So what we want to know is we're very good at telling where it is on the hill. We're very good at telling how big the snowball is, how fast it's going. Because we can do blood tests to measure the calcitonin levels. We know the bigger the tumour bulk, the more the calcitonin. We're very good at scanning. How big is the lump? Where is it spread? So I'm going to use a term here, because you'll hear this term over the next 5, 10, 15, 20 years. It's important we understand it. We're going to talk about progression-free survival. That means how many years have you gone without any evidence that the tumour's progressed? That doesn't mean how many years of survival you've got. It means how many years your tumour's been stable for. We're interested whether it's gone back up, but that's progression, that's something different. But progression-free survival is how many years you've had between scan A, that says it's here, and scan B that says it's spread a bit further or it's got bigger. Now to get that information, we've got to scan you all the bits in between as well. Otherwise we don't know. Right? So the evidence at the moment would suggest that in some people, some tyrosine kinase inhibitors, because there are a whole family of them, improve progression-free survival for patients with metastatic medullary thyroid cancer. That's the kind of bottom line. What we need to ask as users of that is, well, how many people had to drop out because of side effects? And we have to have an honest conversation with the people that we look after and help about how important progression-free survival is. That's the difficult conversation, because it's you don't know you've got progression-free survival unless we scan you lots. And again, this is about understanding it from the person's perspective, not the doctor's and the nurse's perspective. I know how difficult it is to get told you need another scan. I know that your life goes on hold for 2 or 3 weeks running up to it, and it goes completely to standstill for the week until you get told what the result is. I know that if you have a conversation around, do you want to be told by the post? Do you want to be told in person? Do you want to be told on the phone? But if it's post, every day after your scan, when there's the plonk on the doorstep and it's a letter, you go and look at it, see where it's from. I know when you see it's from the Royal Victoria Infirmary at Newcastle, you go, bloody hell. Yeah, heart rate goes up. I know if every time the phone rings, you think this is it, they're going to tell me. What we don't do is measure the impact that that has on people's lives. I know it because my family's been through it, so it's like everything stops. And it gets a bit shorter as years go by. You don't get quite as wound up for quite as long before, and you're beginning to, you sort of expect it to be good news, so you begin to kind of relax a bit. But it never goes away. It never goes away. So to even measure progression, here's the irony, to even measure progression-free survival, we have to inflict psychological harm. But we don't ask. So you need to tell us.
Can I just ask the analogy of the snowball getting
Yeah.
bigger as it goes down the hill? Is that meaning that when MTC spreads, it's a bigger problem than it originally was?
Okay.
Or-
No, it's about, so there's this thing in biology called the doubling time. So if you're a cancer cell, if I can just use the word, if you're a cancer cell, you will divide at the same rate. Yeah? So it takes you the same length of time to go from 1 cell to 2. There's 2 cells to 4. There's 4 cells to 8. Yep. You're programmed in. So the doubling time of the cell stays the same. But if I'm 2 cells and I go to 4 cells and I go to 8 cells and I go to 16 cells, you might not see that. But if I go from 4,000 cells to 8,000 cells, I'm going to see that. Right? Right? If I go from 30,000 cells to 60,000, I'm going to see that. And I'm going to see that on a scan. And it's gone from something that's moderately small to something that's quite big, or it's gone from something that's quite big to something that's very big. But actually it's doubling at the same speed as it always did. So yeah, it gets bigger. But it's an illusion. I mean, it is getting really bigger, but it's not getting bigger faster. It just looks as though it's getting bigger.
Do the TKIs also slow down the growth of the theos?
That's a good question. And so something we need to think about is how we do these studies. Yeah. Because TKIs are expensive and have got side effects, and theos are rare. Yeah. So you might think, well, to answer that question, we need 100 people with a theo, and we're going to give 50 of them a TKI, and we're going to 50 of them not, and we're going to see where they end up in 10 years. That's incredibly difficult to do because no one centre's got 100 patients. And remember that I said about the challenges? One of the challenges is cooperation. 2015, I'm going to be honest with you, we're not very good at playing in the playground nicely together. We're not very good at cooperating. We're not very good at developing common platforms. In the UK, in Germany, we're very good at it. If you're in France, we're really good at it. If you're in the United States, they don't really need to because they've got larger populations. But in the UK, that's not the tradition that we've got. And we need to change that. So we haven't done the study you're talking about. Instead, we've got 1 or 2 units, mainly in the USA and Europe, who've said, we've done this on 10 patients over 5 years, and this is our experience. And there is some promising data to say that it does slow it down. And we've got quite a few people who've done it on 1 or 2 patients. And they report their experience as well. But what we haven't done is the multi-center randomized controlled trial to show that it works. But there is interest because, as we said, or as we implied, the fundamental problem is common. So we should be able to use the same approach. Shall we talk about surgery for a minute? So one of the things now is, if you present with medullary thyroid cancer, we discover it for the first time. This isn't someone whose thyroid we're taking out to stop them getting it. Should everybody get the same operation? Well, we're just going to take your thyroid out, aren't we? Well, probably not, because we don't know how long you've had it. And there's the disease we can see, and there's the disease we can't see. To be honest, I'm worried about this less than you think I am. Because I know we're pretty good at doing that. I'm worried about the stuff we can't see. Why? Because this is a long journey. and if it's going to come back, it's going to come back in the bits outside the thyroid. The commonest place for it to come back is in the neck, in the lymph nodes in the neck. So the question is, when we discover someone's got MTC, should they all have the same operation? And I would say no, they shouldn't. We should be asking 2 questions. We should be asking, what operation should you have? And we should also be asking, and who should do it? There is evidence increasing, there is good evidence that if your calcitonin level is particularly high, above a certain amount, or below a certain amount, that you should probably have a different operation. You should have an operation that takes out the lymph nodes in the middle of the neck and at the side, irrespective of whether the surgeon thinks there's any tumour there or not. I'm interested in what the surgeon thinks at the time of the operation, but there's evidence that you should have central and lateral lymph node dissection if your calcitonin is above a certain amount. If your calcitonin is above a certain amount but below another one, we should probably do lateral lymph node dissection on the side where your tumour is. And then if your calcitonin is below a certain amount, we shall just do the tumour out. So it's about tailoring the operation to the problem. That is based on certain things being the case, though. That's based on, we know it's medullary thyroid cancer before we take the lump out. And there may be some people in the room who didn't know they had medullary thyroid cancer until the lump was taken out. Yep. So that's what we're doing. And it's important to think about who, because not all thyroid surgeons, not all people taking thyroid lumps out can do this operation. So in the northeast, we would have a number of surgeons who will do a thyroidectomy. And our colleague who's a thyroid cancer nurse may know this already. The emerging thyroid cancer guidelines would say that we have something called a diagnostic operation for, not for medullary thyroid cancer, but for other forms of thyroid cancer. The current guidance is that quite a lot of people can do that. But in the northeast of England, if we know that you've got medullary thyroid cancer, there are only two surgeons who will operate on patients that we know have medullary thyroid cancer. And that's Tom Leonard and Richard Bliss. Because they can do this. And some of the other thyroid surgeons can't.
That poses a slight problem as to when you have had an operation, who has done it and have they done it right?
And it does do that,
Because
doesn't
I
it?
mean, my operation was 6.5 hours in September.
Yeah.
And, you know, the sternum was opened up, everything had gone down the thorax.
Yeah.
It got a bit worried now.
No, no. So if you had that,
Yeah,
they did this.
yes they did.
Yeah.
Yeah.
Can I ask where you had your surgery?
That's St James's.
Yeah.
Mr. Whitehead.
Yeah. So they're very good here. And I guess really what I'm saying is this is about developing services so that the right person gets the right treatment. Right? And it sounds as though if you had a sternal split,
Yes.
that's kind of high-end stuff.
Yeah.
Yeah. And that's why we got to develop a community of professionals and patients who can have these conversations. So the real thing, or the elephant in the room, the elephant in the room when I showed you about we would be doing operations, prophylactic thyroidectomies in children under 2. Yeah. I used to go around speaking to Barney in Sheffield and your colleague in Leeds saying how many surgeons in the UK should we have doing prophylactic thyroidectomies in 2-year-olds? I no longer do that. I go around saying how many people in Europe should we have doing prophylactic thyroidectomies in 2-year-olds? They're pretty little, you know. And we've got to get better at having these kind of conversations. It's important.
How does this impact on NHS commissioning?
Yeah.
GPs don't know this.
No, they don't. So, and we could have a whole conversation about the NHS in a way.
What's the importance of specialist service?
So this is specialist service
If you're in a
commissioning.
specialist unit,
Yeah.
then they know who
Yeah.
the surgeons are.
So,
Who needs to be referred to.
so primary care in England is commissioned from NHS England. Yeah, NHS England commissions primary care, and it puts in charge of the development and the running of local health services. It puts the NHS England has set up clinical commissioning groups. Those are groups of primary care physicians and hospital physicians who say what services are needed locally, yeah? How to do it. But there's an understanding that there are certain rare conditions that each individual area, and for instance in Newcastle we used to have 3 clinical commissioning groups, they've now all fused into 1. In Manchester they used to have 3, there's now 1. Those of us who've been in health a long time think this looks an awful lot like what primary care groups used to look like. Anyway, but there's a group of conditions which no one CCG will have enough patients with to develop an expertise in knowing what to do. And to address that problem, NHS England has developed something called specialist commissioning groups to look at commissioning specialist services. And endocrinology is one of those specialist commissioned services. And so it's looking to say, how are you going to do this specialist stuff in this area? And I don't know how it's run in Leeds. I know a bit about Manchester. I know a lot more about Newcastle, where they will be looking for originally one hospital to take on the responsibility for delivering specialist endocrinology care, and that includes surgery and the treatments around it. The buzzwords, having just been at the King's Fund for the last month or so, the buzzwords, well, they actually don't have to be in all one hospital. It's about whether you can coordinate services to provide a single shared service to serve the needs of the population. So, for instance, in Newcastle, we are in different hospitals, but we're in one trust. We have the thyroid cancer treatment at a different place to the surgery, at a different place to the follow-up, but they're all under one umbrella organisation. In another city, in Manchester, for instance, you might have the thyroid cancer treated at the Christie, but your follow-up might be at another trust. but they have a shared understanding of what the service looks like, and they coordinate it in a particular way. And you're right, it's about then saying, we are then audited by the NHS England to say, well, tell us how you're doing this and give us feedback, and I have to fill in a spreadsheet every 3 months per quarter, giving all the number of patients we've seen, with what condition, what complication rate, how many days our patients have spent in ITU, how many patients have been readmitted after thyroid surgery within 30 days, etc., etc. And we're laid out in a dashboard. And any of you involved in quality management? It's a RAG dashboard we've got, so I've got all of these squares, and they go red, amber, green, red, amber, green, red, amber, green, and they tell me where I am in relation to all of the other units in the UK. And I like seeing green, and I really don't like seeing red, and my hospital managers really, really don't want to see red. I'm going to talk about 3 gut problems in MEN2b. Start with the easy one. There's nothing wrong with your gut at all. It just does what it's told to. The gut is not a passive tube that just goes from here to here. It's built of muscle. It's got nerve cells in it, and it works in a really, really coordinated way. I eat my breakfast. I had the muffin on the train. Something very predictable is going to happen. My stomach's going to sense it. It's going to swish it around a bit, and then it's going to push this bolus of muffin and coffee into my next bit of gut that's then going to push it all the way through. Hours later, something else happens. Yeah? It's a coordinated wave. What if that didn't happen? What if I ate something and my small intestine predicted at the wrong time it needs to... anyone been in a football stadium and seen a Mexican wave go around? Yeah? They're cool when they happen, aren't they? What do they look like when they don't work? Do you ever feel like a bit of an idiot? You're standing at home. Right. Oh, sugar. Right. And the best way to stop a Mexican wave going round isn't to put a tannoy out saying the next person to have a Mexican wave will be ejected. It's for one section of the crowd to stand up at the wrong time. Because then you get the wave going both ways. And there's this collision somewhere at the wrong point. Yeah? Well, if your gut doesn't work in a coordinated way, it's not pleasant. Yeah? And that coordination is dependent on the nerve cells communicating with each other that are in the lining of the gut. And it's dependent on your gut responding to hormones made by your pancreas and your stomach telling it that something's coming. Problem number 1 then. One of the hormones that's really good at telling your gut something, that it has to do something, is calcitonin. Can anyone remember having a calcitonin stimulation test? We don't do them anymore, yeah? I used to, when I started training, there was the protocol. This is how you do a calcitonin stimulation test. Pentagastrin test, yeah? And it was this amount of pentagastrin, this amount of thing, and you had this, and the sisters on the program investigation, Newcastle, used to have it all written out. And they'd be, and you have a bowl. And I would go, well, what's the bowl for? And they go, you'll find out. Right? Yeah. There weren't a lot of people who wanted a second one. Very few people who wanted a third one. Because it made you feel terrible, didn't it? Everybody vomits, you get diarrhea. Calcitonin's really good at making you feel sick, and calcitonin's really good at giving you diarrhea. So if you've got a tumour that makes calcitonin, problem number one is one of the side effects of that, irrespective of where it is that it's making a hormone, the tumour's making a hormone that's going to give you loose stools. And it's very common for our patients who've had medullary thyroid cancer for a long time to get into problems with diarrhea because their calcitonin levels are so high, it just makes the gut work overtime. The only way we can treat that is to try to find a way to get the calcitonin to come down, which can be difficult, or give stuff to bung you up, which actually is quite effective, to be honest, if it's done properly. So that's the commonest problem. Problem number 2 in MEN2b or MEN3 is that everyone's seen pictures of people with MEN2b with mucosal neuromas on their lip and tongue. Yeah? Well, those are just the neuromas that we can see because they're on the outside and they're visible. But there are lots of other surfaces in our body that have got nerve cells close to the surface that are harder to see. One of them is in our eye. And you heard Chris talking about his eyes being looked at when he was in hospital. We're looking for corneal neuromas. Biggest surface area of your body where you can't see, but there are lots of nerves running close to the surface, is lining your gut. And if you get a big neuroma in your gut, in your large bowel, it can look like that. If it's a very big one, it can look like that. Now I might think, well, that's really not a problem. It's a flexible tube. Stuff can get round it. But remember, this is a tube that sends a wave of contraction down. So to put it bluntly, it doesn't care what it sends down. Can't tell the difference between a bit of poo and a neuroma. It will push. And it will push this down. Push it down. And you can get, actually it contracts around and it gets stuck. And you get something called intestinal obstruction. Because all of the activity is still going on up here. The wave's still coming down. It's like, come on guys, get through. But there's a roadblock. And that's unpleasant. And can require hospitalization and can require emergency surgery to take away either the neuroma or the affected piece of bowel. Problem number 2. Problem number 3 is that we've known for a long time there's a disease that presents in children called Hirschsprung's disease. I've told you that the gut has this coordinated wave of activity to push things through, and that it's the nerve fibers, what we call the nerve plexus in the wall of the gut that coordinates that. In young people who present with Hirschsprung's disease, there's a part of the bowel where that nerve plexus never formed. So it's like there's a muscly, ripply, fully active bit of bowel here. There's a muscly, ripply, normally active piece of bowel here. But in the middle, there's just this tube that doesn't really do anything. It's passive. Now, if that's a small bit of tube, you can imagine that there's a pretty lot of activity here, pushing stuff through. There's a lot of activity here, pulling stuff through, so you get over the block. If this is a really long bit of bowel, that's not going to work. And you're going to get stuff stuck. And you're going to present as a child with serious end constipation. Everybody laughs and jokes about constipation, but actually this is sort of life-threatening constipation because there's a roadblock here and there's a build-up before, and that's serious intestinal obstruction. Why are we talking about Hirschsprung's disease in MEN2? It's been known for about 10 years that some forms of Hirschsprung's disease run in families. And actually, the same molecule, RET, that's involved in MEN2, there's a problem with RET in that too. But instead of RET being permanently switched on, like it is in MEN2, in families with Hirschsprung's disease, it's permanently switched off. And that seems to have, as one of its impacts, that the nerve plexus in the developing gut doesn't develop. Now, it turns out that in some families with some RET problems, the RET mistake they have is switching it all on in the thyroid and in the adrenal gland, but it's switching it off in the gut. So you have these families with MEN2 plus Hirschsprung's disease. They're rare. We've got 2 of them in the northeast of England. And the impact on the family and in the individual purely depends on how big the segment involved is. If it's a small segment, we can get by with laxatives and change in dietary advice. If it's a large segment, then effectively we have to treat these young people in the same ways we would if they just had Hirschsprung's disease. We have to take out the affected piece of bowel. And if it's a very large piece, that can lead to longer term problems. If it's a smaller piece, it's a bit more straightforward. But it has a big impact on their lives.
Have you tested for Hirschsprung's?
Normally, people, we would do it on history. What's the, do you have a history of constipation, intestinal obstruction, etc., etc., etc.? That would be the first step. And it's the kind of thing that if you've got, you know about it, if you see what I mean. You wouldn't, it would be very, very unusual to go through decades of life and not know you had Hirschsprung's disease. I suppose it's possible.
It's gone through decades of life with constant diarrhea. Would that be Hirschsprung's? How would you know?
Yeah, that would probably not, but that's a good question. Because sometimes when people have got constipation, everyone thinks, well, how can you get diarrhea when the problem's constipation? Well, actually, you can get something called overflow. So this is where there's a block in the bowel, but upstream, things are very runny, and the only thing that gets by the block is the runny stuff. So you can have long-term diarrhea, but actually the problem's the opposite.
And the Hirschsprung's is more associated with MEN2a, isn't
Yeah.
it? And the
That's
other
true.
obstruction is
2b. So this bit, when you've got a ganglion neuroma that's pushed down and gets stuck, that's a 2b problem, or 3. The association with the Hirschsprung's, that's a 2a problem. Well, in that we talk about we've had a bit of bowel taken out as though it's problem gone, we'll walk in the park after that. But actually, you've got the amount of bowel that we've got for a reason. And we take a bit out, and it's naive of us to think it's just going to be a walk in the park after that. But for 2 reasons. One is it's shorter. And the second is, remember I said this is a coordinated wave that goes through, and it's dependent on the nerves working, and that's dependent on the nerves connecting. I've taken 2 bits of pipe, and I've cut a bit out, and I've stuck them back together again. The bits of pipe are stuck together, but the nerves that run between them, they're not stuck together. So it's not going to work in exactly the same way.